Big cities are no strangers to drug busts, but it's no longer just a big city problem. In fact, opioid abuse and addiction is a big problem well beyond Ontario's urban centers. Joining us now to discuss what's behind this surge, in San Diego, California, Dan Werb. He's Director and Scientific Board Chair of the International Center for Science in Drug Policy. And with us here in studio, Ada Giudice Thompson, Vice President of the Advocates for the Reform of Prescription Opioids. Tara Gomes, Principal Investigator for the Ontario Drug Policy Research Network. Detective Constable Mike Howell, he's with the Sarnia Police Service. And Michael Parkinson, Community Engagement Coordinator with the Waterloo Region Crime Prevention Council. And it's good of all four of you here in studio, and Dan down in California, for joining us today. We thank you very much. Let's set up the discussion with some, if you haven't followed this, rather astonishing facts. We'll get these on the table right away. Canada ranks second in per capita opioid use. Ontario ranks first in Canada in per capita opioid use. People aged 25 to 34, 1 in 8 deaths were related to opioid use. Those figures from 2010. It is the third leading cause of accidental death. That's more than double the number of deaths caused by motor vehicle accidents. Those are some pretty unusual and astonishing revelations. Dan, I want you and Detective Constable Howell to start us off in this discussion. We'll start with you, too. We're seeing a lot of headlines lately about why people are dying from using drugs such as fentanyl and other opioids. And I want to know why this is. You know, there'll be a lot of people who don't know much about this. Why is this in the news so much lately?
Well, I think part of the reason is this is something that's been happening for over a decade now. And there's been a steady increase in patterns of overprescription of prescription opioids like OxyContin and Percocet. And Ontario is no stranger to that phenomenon. So while we're seeing these headlines now about overdose deaths, it's really been something that's been occurring for 10, 15 years. And unfortunately, we've reached a point where governments have responded, policies have been changed to restrict access to some prescription opioids that were previously overprescribed. And now we're seeing a market that is really in flux in a lot of ways, and people are therefore resorting to more dangerous drugs.
Dan, let me follow up on that, because you were on the program a year ago, and we talked about in southwestern Ontario a kind of an outbreak of OxyContin use. And, that brought us up to speed on the issue of Oxy being the dangerous drug. Now, it's not Oxy, now it's fentanyl. What happened?
Right. Well, I think a lot of this issue is related to good intentions to try to reduce access to OxyContin and Percocet, which people were flagging as a dangerous drug, as two opioids that were being overprescribed to people, and after that resulting in some high levels of opioid dependency and drug dependency, which was obviously problematic. So there have been efforts to reduce access to prescription drugs like OxyContin and Percocet. Purdue Pharma stopped producing OxyContin, replaced OxyContin with a tamper-resistant formulation of the drug called OxyNeo. The provincial government in Ontario sought to restrict access, along with the Ontario College of Physicians and Surgeons, to try to change the way that, to reduce basically the high levels of pills that were being prescribed to people. And a number of controls were set up in pharmacies to ensure that people weren't double dipping, going to different pharmacies to try to get the same prescription filled twice. So in a lot of ways, this was really effective over the past few years, these systematic efforts to reduce access. But unfortunately, the prescription drug market does not exist in a vacuum. It's inextricably linked to a market of diversion of pharmaceutical drugs, and also the black market of street heroin, street opioids like heroin.
Okay, let's unpack that if we can for a second, Dan. I'm going to go to Mike now. Mike Howell. Like, Sarnia is not Toronto or New York City or Chicago. It's not one of the big cities in North America, and yet I'm told You spend a lot of your time dealing with this subject. How much of your time would you estimate is wrapped up in this issue?
Primarily, we're seeing crystal methamphetamine or we're seeing prescription opiates. We see very little cocaine. We don't see any heroin. It really doesn't exist in any large quantities in our area. But primarily, that's what our investigations entail. It's either prescription opiates that people are diverting and selling, or crystal methamphetamine, or it's a combination of the two. We see drug dealers who will sell whatever generates them the largest profits and whatever the need is in the community. And unfortunately, that's primarily opiates.
Where were you before Sarnia?
I was with Peel Regional Police, and I've been also with Durham Regional Police. I was a drug enforcement officer out there. So that was 2008 to 2011. I was used to large-scale drug investigations. I was used to crystal methamphetamine, or not necessarily crystal. I was used to crack cocaine, some ecstasy, mostly marijuana. And then when I switched over to Sarnia in 2011, it was all crystal methamphetamine. It was all prescription opiates. I'd never seen so many needles in my whole life. It just wasn't an experience I was used to. So it takes a bit of an adjustment. And unfortunately, it seems like Sarnia in our particular areas is really hard hit by these types of opiates.
Why do you figure?
It's hard to explain. Some people say, is it because Sarnia is right on the border? We're on the border with Port Huron in Michigan, but it really has nothing to do with it. For us, I don't think we're quite in the drug pipelines that some of the larger communities might be. So when it comes to heroin or mostly crystal methamphetamine or cocaine, that's going to the larger urban centers like the GTA. For us, there's such the availability of prescription drugs that is the drug of choice, really, in our area, as well as the crystal methamphetamine. The crystal methamphetamine is coming from other areas, London, Hamilton, Toronto, that type of thing, or Windsor, and being brought back to our community. But it's primarily opiates now that we're having to deal with on a consistent basis.
Dan, let me go back to you in California. There is this, I guess, conventional impression we have that a lot of this kind of thing happens in back alleys or in the shadows, away from prying eyes, that type of thing, maybe junkies getting lost in the big city. How accurate is that impression that we may have of how things really are?
Certainly that still exists, and there's a number of places, in major metropolitan areas where the back alley is the only place where people can avoid police, avoid prying eyes, and that's where they're going to do their drugs. But in the case of smaller, rural, perhaps agricultural areas across Ontario, that isn't the case. And when it comes to prescription opioids, a lot of it actually starts at home. And that's what, in my investigation of this issue, when I was doing some reporting in Chatham County, a lot of people were talking about the fact that they first discovered prescription opioids in their parents' medicine cabinets, or a spouse started using the opioids that had been prescribed to their partner, and became drug dependent that way. So it's a lot more intimate. It's not just something that's happening in back alleys, and in fact, it's happening in pharmacies, frankly, and in doctors' offices where these drugs are sometimes overprescribed.
I don't know, Mike, if this question is answerable, but is there, in your travels, a typical user of these kinds of opioids?
No. It can be anyone. There's no, it doesn't differentiate between your social class. It doesn't matter where you are on the totem pole of life. You can be at the bottom, you can be anywhere up to the top. We have deaths that are in $1 million homes. It doesn't matter. These drugs are so available to anyone.
More male than female?
More male than female, yes. In our area specifically, when we're talking about, there's been recent statistics that have been released by Lambton Public Health where it stated about our opioid problem specifically for Lambton County. So that includes Sarnia and some of the outlining areas. We have, for the number of emergency room department visits in relation to some sort of opioid diagnosis or complication or overdose, for our statistics, we have 80% higher than what the provincial average is for our male population, 55% for our female population. We see a huge difference between, as bad as it is in Ontario, our area unfortunately is much worse. It just seems with this type of problem. We're also finding that the age group that typically is at risk is 20 to 29 years old, and they are 3 times more likely to have to go to the hospital for overdose or some sort of treatment in relation to opioids.
Why is that?
It's hard to explain in our area. I'm not sure if it has something to do with some of our geographical location, that we are a little bit more remote from, like I said, most of the major pipelines. But there really is no rhyme or reason about why this is affecting us.
If you're a 24-year-old
badly.
young man, you think you're invulnerable to anything, so
Yeah.
you no doubt overindulge.
Sure.
Right?
Sure. It just seems that population in our area we have the most problems with when it comes to these issues.
Is this an epidemic right now?
It is. It is for sure.
Even in small cities and towns in Ontario?
Yes. Yes. Our fentanyl death rate is 4.5 times the provincial rate, which is shocking. As bad as it is across the province, like I've stated, and even across Canada, we have 4.5 times the rate. We have the same number of fentanyl deaths as a larger city like London would have, which is 3 times the population that we have. So there's a very high amount of concern that we have, as not only on behalf of Sarnia Police, but all the partners that are involved in trying to tackle this issue.
Tara and Michael, let me get you now to join our discussion, and I want to start with you where we finished up with Mike and with Dan. Do you think this is an epidemic across the province of Ontario, what we're talking about tonight?
Yes, I absolutely do. Some of the work that we've done and really echoes what Dan and Mike have already said, and that this is a huge issue that's been rising over the past 2 decades across the province. But also when we look at the individual counties and regions, we see huge differences in the rates of prescribing, the rates of people going to hospital with an overdose, and the rates of deaths from overdoses. And it's really difficult to try and understand what's driving that. Is it proximity to the border? Is it, the typical age range of people? Some different areas might have more older people versus younger people living in the regions. Or is it something else? Is it that there are certain prescribers in some regions who are more comfortable prescribing these? Or might we even hear some concerning stories of prescribers who are involved in overprescribing these intentionally for the purposes of diversion? And so you can have just a couple of
Just explain what that overprescribing for diversion means.
So writing a large number of prescriptions for patients that they know are going to be then turned around and sold on the street, and perhaps getting paid for that service.
I don't mean to sound naive, but pharmacists do this.
Prescribers
Doctors do this.
There have been some cases of this, and I mean, you probably know better than I do, but in the work I've done, I've heard from different police services who have said, yes, this happens, and it can be the prescriber, it can be the pharmacist, it could be a combination of the two working together with people, and you probably know this better than I do.
I believe there was a Barrie family physician or a doctor that got caught up in this diversion of fentanyl, and is going to jail for a number of years, I believe. And these were huge amounts of prescriptions that were being written. I believe the value was somewhere close to $400,000 worth of this prescription drug that was being diverted onto the street.
Just to get a sense of that, if you buy a typical prescription, pills in a bottle, how much does that cost?
Very little, especially if you're covered under a drug benefit
So
plan.
400 grand's a lot.
Absolutely.
Okay. Can I get to you, Michael, on that issue about whether or not in your travels you see this as an epidemic?
Well, it's been described as a leading public health and safety concern. It's been described as a public health crisis. Whether it's an epidemic, I don't know. We lose 1 person every 14 hours in Ontario to an opioid-related overdose. If that's not a crisis, then I think we need to redefine what a crisis really is.
We lose meaning someone dies.
Someone dies every 14 hours in Ontario using 2013 data. So in total, that's 625 people across Ontario in 2013. That's up 463% since 2000. That's almost 5,000 dead Ontarians. And many of those deaths were absolutely preventable, and many of them, as Mike said, started in a physician's office. But before they got to the physician, they were approved by regulators, and they were approved by provinces and the federal government on their drug formulary plans. And here we are. I often think from a crime prevention perspective, what would happen if we dumped billions of dollars worth of pharmaceutical grade heroin through trusted health providers into a largely unsuspecting public? Like, what could go wrong? And
everything.
Everything could go wrong. And we have the knowledge now and the data through the good work in Ontario from Tara and other researchers. We know enough to know better.
Here's, apropos of the numbers you just said, Sheldon, let's bring up this bar graph here because we happen to have this standing by. Ontario opioid-related deaths going back to the year 2010 up to 2013, which is the latest year for which statistics are available, up and up and up and up. And I don't suspect we have any reason to assume that over the last couple of years, this chart is going to continue to go up, right?
No, it's been rising. I would expect it would continue to rise. Opioid prescribing has leveled off a little bit, but of concern is high-dose opioid prescribing. So like fentanyl, like oxycodone, that is up. And so what's interesting about those numbers, like those 2010 to 2013, it's about a 20% rise in opioid overdose deaths. For the same period, there's been a decline in self-reported opioid misuse. So I think we really need to ask ourselves, what's driving opioid overdose deaths? What's driving other indicators of mortality like addiction treatment and emergency room admissions and visits? And many people who are smarter than me would suggest that it's people using as prescribed that is driving this epidemic. That we often focus on, that stereotypical notion of a junkie in the street, and it allows us to, in the main, pass moral judgment on people's character and be dismissive of services. I think we really need to look at people who are using exactly as they're prescribed by their physicians, particularly people who are getting mental health medications like antidepressants or sedatives, and start to reduce the deaths attributable in those circumstances as well.
That is a brilliant segue to you, Ada, because this is not an academic exercise for you. This is very personal. You want to tell us about your son?
Yes. Michael had some pain one morning, and he was doubled over. I took him to the Emerge.
He's how old?
He was 27.
At the time?
At the time. Okay. And so we went to Emerge, and they said he has renal colic, which is kidney stones. They gave him morphine, Gravol, inserted a catheter because he could not void his bladder. So when all that was done, he was feeling really good. I said to the doctor, what happens if this pain comes back again? What do I do? And he said, don't worry. And he gave us a script for Percocet. But in 2002, I didn't know what Percocet was. The doctor said nothing. I took it and went directly to the pharmacy, had it filled. Again, nothing said about the fact that it was an opioid and highly addictive, nothing at all.
So
and I gave
doctor didn't say that, pharmacist didn't say that?
Didn't say that at all. And I gave it to Michael. Now, of course, I had told Michael about, street drugs and what have you, but I trusted the system, I trusted the doctor, the pharmacist, and it was 2 years from that first prescription. Michael was gone, in bed, at home. I went off to school, to work, and he never woke up. I unknowingly left him to die because I went to turn off his alarm clock. And I thought, oh, he probably got to bed very late. And I thought, I'll let him sleep some more. His girlfriend, somebody will come by, And I went to work.
Difficult conversation, obviously, and we're grateful you're here to help us understand this better. Did you have any reason to suspect, while Michael was taking the medication, that he was addicted to it or taking it improperly or anything like that?
Not at all. Not at all. He was given this in 2002. He had recurring bouts of kidney stone, and we went back to the same Emerge and given the same prescription again after the whole treatment. And I noticed 1 year before he died that he was different. And I couldn't quite put my finger on it, but he had a partnership, a business that he was doing really, really well in, and that deteriorated. He was extremely close to family, relatives, and that sort of started to fizzle. And I thought, what is going on here? And he said to me, don't worry, Mom, I'm seeing a doctor. So I sort of left it at that, and I really didn't know the details until the day he died, and the police were at the house and the coroner was there. But I want to sort of address some of the issues that you raised earlier. The problem with illicit drugs, this fentanyl, the problem that we're experiencing now, from all of my reading and research, it is from the medical community prescribing, like Michael indicated earlier, pharmaceutical grade heroin. That's what opioids are. They come from the opium poppy.
Do you know whether or not, though, he was using it as prescribed?
He was.
He was.
He was taking it as prescribed. I learned through his girlfriend. He took it as prescribed. He did not crush, he did not snort, he did not inject. And this is where the problem is. As if magically a doctor will give you a pill, you will take the pill, and it won't affect you in any way. They've done studies at Columbia University where they've taken people who inject heroin and people who will inject oxycodone, and the result is the same, and they actually preferred in the study oxycodone. So I think
because it was more addictive and bigger buzz and all of that stuff?
Yeah, but whatever. Yeah, they liked it more. And I think from my experience, what I haven't seen is we can't deal with the illicit drugs without looking at a system that allows these drugs, that sanctions these drugs out to doctors to prescribe. Health Canada has approved so many of these opioids. We don't need any more opioids, and we need informed consent. And that doesn't mean just sign on a dotted line when the doctor decides, okay, you're going to have this for chronic pain, long-term, chronic opioid therapy. We should be told from the get-go that this is an addictive substance.
Michael, I want to go back to you and find out. The temptation will be to sort of stereotype this situation by saying, well, that's a one-off. That's not typical. You've got broader experience, and I want to get a better sense from you. If that's true, is this a one-off, or is this more typical than we think?
No, this is way more typical than Canadians have been led to believe. And Ada's right. Opioids are a substance of known dependence, and we should have learned that 100 years ago when Bayer introduced heroin as a non-addictive alternative to morphine. And so doctors were prescribing heroin at the turn of the century, and addictions went up, overdoses went up, and prescribing regulatory controls were put in place, and we stopped doing that. You skip forward about a century later, and Purdue has introduced OxyContin. Regulators have approved it, physicians are prescribing it, pharmacists are dispensing it, and consumers are taking it and sometimes demanding it. So, and we know, from there was a fantastic coroner review, a review of coroner files out in British Columbia. We know that among people who were taking opioids as prescribed, the death rates were hugely significant. 93% were taking other medications as prescribed by their physicians. So the frame as one of focusing squarely on abuse or tamper-resistant formulations is the wrong frame. It really is. When people misuse opioids, most of the time they're taking it orally. So how an abuse-deterrent formulation will deter is beyond me. It must be magic. And then, second most common form of misuse is by snorting, and third on the list is injecting. So all those people are absolutely important, but we're missing it if we frame it squarely as one of abuse.
Let me go back to California. And Dan Werb, you've done a lot of research on this as well. So I want to find out from you whether you think you have adequate data to come to a conclusion as to whether or not this is a big problem of illicit use versus use as prescribed and just not working properly. What's your view?
Well, I absolutely agree with the other people on the show that the problems we're seeing are generated out of a totally legitimate or sort of legitimate prescribing system. And the issue here, like Ada said, was that we've had influence by big organizations like Purdue Pharma who produced a textbook on pain management that was inserted into a pain management classroom for U of T medical students at the University of Toronto, which downplayed the addictive potential of drugs like OxyContin and Percocet, which were conveniently produced by Purdue Pharma itself. So there's been misinformation. Purdue Pharma in the United States has been successfully sued for fraud over claims that their products aren't addictive. So that is a major issue, that these drugs have been absolutely mischaracterized in terms of their addictive potential. The other issue that I think is relevant and is gaining steam right now is the fact that we're seeing as access to drugs like OxyContin is decreasing through restricting of prescribing, there is an increase in the level of illicit use and diversion of more dangerous drugs like fentanyl. Fentanyl, both produced through and prescribed or diverted through again, legitimate prescription practices, but also now we're seeing counterfeit fentanyl, illicit fentanyl produced overseas and shipped to Canada and disseminated into a black market, and people taking it without even knowing what it is.
Tara, I do remember, it was either last year or the year before, the Ontario government said, we're banning OxyContin, no more allowed, thinking that would presumably reduce this problem. It hasn't reduced the problem.
And that's exactly the situation we're in, as others on the panel have said, and that any one policy that addresses one single drug within this class can't work. And that's because there are so many different drugs in this class and they can all be abused. And so you introduce these restrictions on OxyContin. It was pulled by Purdue and OxyNeo. The Tampa deterrent form came in, but then the provincial government here decided to introduce a lot of restrictions around access to that through the drug program here. But what you see now is fentanyl use is going up, hydromorphone use is going up, and the solution can't be introduced tamper deterrent formulations for all of these products, because even once OxyNeo came in, which was tamper deterrent, you immediately saw chat rooms and traffic on the internet saying, well, this is how you get around the tamper deterrent products. So people have a vested interest in extracting the drug from these formulations, and they're going to find a way. And so I think we need to go beyond just speaking about tamper deterrence. And I think looping back to the discussion around illicit versus prescription opioids, I think the situation in which we're in is that you can't separate the two. I think that the trust that people have that these are regulated and that these are prescription medications and so are safe, then translate into these illicitly manufactured drugs that are being manufactured to look like OxyContin or to look like a fentanyl product, that people then think, oh, well, this is a drug I know. This is a drug that is a prescription medication. I've taken it before and achieved a certain high. And in fact, what we're finding is these fraudulent OxyContin tablets can include one of a number of different drugs, including oxycodone or fentanyl or heroin or cocaine or any of other drugs. And so you don't actually know what you're getting. You think you're taking a prescription drug that while you're misusing it, you have experience and have had a certain experience before. And it could have one of a number of drugs at a number of doses. And just taking one tablet at a dose that your body's not used to can lead to an overdose fatality.
Well, that leads to my next question. Is the impact on each individual basically the same, or are some people more susceptible to having problems with this than others?
It can really vary. We have seen that people who have past issues with addiction, so people who might have past alcohol use disorders, may be more prone to becoming addicted to other drugs. And that's why when people are talking with prescribers about whether to start a patient on one of these medications, they really need to have that conversation and take that patient history to understand if they might be at greater risk of becoming addicted to one of these products.
How long can it take to get addicted?
It can be quite quick. I mean, it would vary by person, but I think part of the concern is what dose you start on. How quickly your prescriber might escalate that dose, and those side effects of those high doses. Some of the work we've shown is that people who are getting these drugs are, a quarter or a third of them even are getting high doses, which in the Canadian guidelines and US guidelines are suggested to be upper dose thresholds beyond which you should be extremely cautious at prescribing these drugs. And a quarter to a third of Ontarians are getting drugs at doses that exceed that.
Sorry, go ahead,
We're
Mike.
seeing that, unfortunately, that some of the prescriptions that are coming through after we've done drug investigations are way above what they should be. And it's unfortunate that that seems to be the trend with some people. Like, we had a gentleman who was prescribed a certain amount of fentanyl and pills. He got his prescription the one day. The next day, we did a search warrant. All of that medication, besides some pills, was gone, was already diverted onto the street. Every time this gentleman was getting a prescription refilled, it's $20,000 street value of the drugs. And there's such a huge market and demand for this stuff that people are begging to take this kind of stuff off of people that do have legitimate prescriptions. And that's partially where the drug diversion angle of things comes into play.
I presume, though, that because this isn't cocaine or heroin, which are clearly illegal, these drugs are legal, that makes your job harder, yes?
Yes, very much so. So, you know, you could walk around, if you're prescribed fentanyl or hydromorphone, you can walk around with that in your pocket and it not be illegal. It only becomes illegal when you attempt to divert it, to traffic it to another individual. So it does present some challenges for policing, especially in small communities.
Do you have to catch them in the act?
Pretty much.
Otherwise?
It is very difficult for people who do have a legitimate prescription for us to provide some sort of enforcement. Otherwise, then we're almost going into the reverse engineering of a drug investigation. So, like I said, person who has a prescription, all of a sudden the next day after they've had it filled, they don't have it. Then we have to look at production order of medical records and reverse engineer a drug investigation, basically, instead of just your typical one that involves just product going out and someone being illegally in possession of those drugs.
Ada, given everything we've heard tonight, I want to make sure I understand your position. Are you saying there should be no prescribing of these medications at all anymore?
No, that's
You're not saying that.
what I'm saying.
Okay.
What we have to do is pull back on the prescribing of opioids because they are addictive. And you don't, like I said earlier, you don't have to abuse them. And the doctor can go through a questionnaire with you to see if you consume alcohol, you're a smoker, whatever. They can use opioid risk tools. They can do all those things, monitor you closely. It doesn't matter. And there's a new paradigm now for doctors in the United States. They're saying, we need to still continue to prescribe opioids because pain, there's 100 million, I think it is, people in pain and they're suffering, but there is a relationship between the increase in sales and the increase in addiction and in overdose deaths. And I want to also comment, in the United States, there was a study done in Utah. 92% of the people who died were people who were taking their opioids as prescribed. They spoke to family members. The family members thought that they were addicted, but they were taking their pain medication for their chronic pain that they were experiencing. So this is a problem that needs to be synergistically addressed by everyone, all of the stakeholders.
So we're talking Ministry of Health, we're talking doctors, we're talking
Federal
pharmacists,
Health Minister,
Health Canada.
Everybody, OCP, that's right. Because when Michael died and I went to meet with the registrar at the OCP, CPSO, the coroner's office.
Hang on.
Okay,
Acronyms.
Ontario College of Pharmacists, the College of Physicians and Surgeons of Ontario,
Okay.
the coroner's office. I got the same story, that if you take these pain medications correctly for pain, you don't become addicted. But pain and addiction are not mutually exclusive. They all said to me, well, that's not our purview. You have to go here. The coroner said, we can only make recommendations and nobody will listen.
So somebody's got to pull
so
all
they're
the stakeholders
all
around the
doing
table.
this, yes. Right. It's all of our responsibility. And patients as well, because once they're addicted, even if they're pain patients, you can't take their supply away from them. If they stop taking that opioid, they go into withdrawal. So they think, oh, when I take it, my withdrawal, my pain disappears, I must need this medication. So they are one of the major groups that really are determined, don't take my meds away. But we do have to. There are other ways to treat pain in addition to opioids, and they should be given only in select clinical situations when it's warranted,
So
when
let's
the
get some-
risk is not greater than.
Understood.
Okay.
Let's get some feedback from around the table here as to what kind of, if I can mix my metaphors here, prescription for change might improve things. For example, what would you like to see happen?
Well, currently there's Bill 33 for the fentanyl patch-for-patch exchange program.
What's patch for patch?
Basically, it's a partnership between patients, pharmacists, and physicians, as well as other public parties like Lambton Public Health, in our case, and Sarnia Police. It's trying to have the responsible use of these drugs and trying to ensure that these drugs don't get diverted onto the street, and that the patients that have them need to return their use patches to a pharmacy after they have, so that they can get a new refill. Because what we're finding is that people are diverting them onto the street in some cases. I mean, these drugs, for some people, they can't live without them. They are, I don't want to classify, especially in fentanyl, that it's an evil drug. It's not the case. For some people, this is all, it's everything to them because they can't live a good quality of life without them. But for the people that are potentially abusing them or diverting them, these cause issues for us. So basically, to ensure that the patient does receive their additional supply, then they have to return those patches. If they don't, then what happens is there's a conversation between the pharmacist and the physician saying that, you know, for example, Mike Howell was supposed to return 10 patches, he only returned 2. We need to investigate this and look into it. And it provides checks and balances to figure out what is going on. Is this a abuse issue for that individual, or is it a, you know, or is diversion going on because they are worth so much?
Michael, let me ask you about, is it naloxone? Is that how you say it?
Naloxone.
Okay, tell me how that's a part of this puzzle.
Well, if you want to reduce opioid overdose deaths, naloxone would be a key part of that solution. It won't drop opioid deaths to 0, but it's...
What is it?
Well, it's an opioid antagonist, so it reverses, at least temporarily, an opioid overdose. It's on the WHO Essential Medicine List, the World Health Organization. It's been used successfully for 40 years among paramedics and in emergency rooms, and you know, across the USA, from the White House to state level to local levels, we see a massive ramping up of naloxone access, expanded naloxone coverage.
So if you take one of these opioids and you take naloxone at the same time, you should be okay?
No. If Steve takes too many opioids and I'm hanging around Steve and I notice that he's exhibiting the signs of an overdose, then naloxone is something just like an EpiPen that I would use on you to save your life. So in an opioid overdose, your brain forgets to tell your lungs to breathe, it's respiratory failure, and it's a proven lifesaver. It costs about $12. It is not widely supported by governments in Canada at the national or provincial level.
Tara, what about doctors and pharmacists? How do we get... Yeah, all right, Dan, come on in. You come on in, then I'll go to Tara after that.
Well, I want to just mention the situation with naloxone. Here in San Diego, colleagues of mine at the University of California, San Diego have worked with the San Diego Sheriff's County Department, and now sheriffs in San Diego County are all carrying naloxone. So these are the first responders, police officers who are carrying it, and interestingly, they're carrying it even before people who are staffing the local needle exchange are willing to carry it. So they've been shown down here to dramatically reduce deaths, and I think that we could definitely see the same level of prevention in Ontario if we had buy-in from law enforcement in particular.
What about, Tara, doctors and pharmacists? Do they need to have the Riot Act read to them by the province or Health Canada or something like that?
Well, I think there is a gaining appreciation among doctors and pharmacists that some of the information they might have learned in medical school or might have learned through their training may not have been unbiased, and that they might need to rethink the way in which they are prescribing or dispensing opioids. But I also think one of the key things that we're missing in Ontario is getting that information particularly into prescribers' hands. The provincial government introduced legislation, and we now have a narcotic monitoring system in the province, which captures all of the prescription drugs that are dispensed in pharmacies. And one component of that allows pharmacists to know if a person might be double doctoring. They might have just got your prescription filled at your pharmacy, but they just yesterday got the same prescription filled at a different pharmacy or from a different doctor. And that's one of those, characteristics of opioid misuse that we look for. But the problem is that information is not in the hands of the prescribers. And we don't have an electronic health system or a database that's accessible to prescribers when they have somebody come in who they think might be in extreme pain and they might be trying to do the best that they can to actually look and see, oh, well, this person actually went to this different emergency department yesterday or got a prescription filled from a different doctor a day before that. And if we could get that information into their hands, I think it would put a lot more power in the prescriber's office in terms of identifying potentially people who might be abusing or misusing these drugs versus people who have legitimate pain conditions. And if they do identify people who might be addicted to these drugs or misusing them, then having them understand how they can get those people help, because you can't just abandon them. Right. How do you then get them help? And I think that that is a piece of information that really we're missing in Ontario, and I think would be a great tool in trying to address this problem.
Dan, I'm down to my last minute here. Can you just take that minute and tell us what you think the general public needs to know about this right now?
Well, I think that it's been stressed before that the pharmaceutical market, first of all, these drugs can be dangerous. I do think that there is a place for pain management through opioid drugs within our medical system, but these drugs are addictive. And I would again stress that an expansion of the distribution of naloxone could dramatically reduce the number of people in Ontario who die of prescription opioid overdoses.
Does that suggest that it ought to be on the formulary for the Ontario Drug Benefit Plan or that kind of thing?
Absolutely. I mean, currently it's classified as a noxious substance. It's a controlled substance. Health Canada is undertaking a review, but we need to advocate around better access to naloxone. I really think we need law enforcement to take up naloxone as part of their toolkit, and I think we could see a major decline in the short term, and then move on to these longer-term policy issues.
Understood. That's Dan Werb, the director of the International Center for Science in Drug Policy, on the line from San Diego, California. Dan, thanks for being on the program again. And here in our studio in Toronto, Mike Howell, detective constable with the Vice Unit, Sarnia Police Service; Tara Gomes, principal investigator and lead Ontario Drug Policy Research Network; and on the other side of the table, Michael Parkinson, Community Engagement Coordinator for the Waterloo Region Crime Prevention Council; Ada Judice-Thompson. Ada, thank you for coming in and sharing a hellacious story with us, and I hope you get some peace and some progress on this to help you going forward. VP Advocates for the Reform of Prescription Opioids. Thank you all very much.
Thank you. Thank you.
Help TVO create a better world through the power of learning. Visit supporttvo.org and make a tax-deductible donation today.